Now we shall discuss selective eye diseases. Glaucoma is an eye disease which causes blindness due to increased eye pressure.
The term glaucomatous cupping refers to an increase in the size of the optic cup relative to the optic disc that occurs in glaucoma. The increase in the cup is due to loss of nerve fibers bundled in the optic nerve. This so-called cup-disc ratio is determined by comparing the diameter of the disc to that of the cup. The optic discs generally should appear symmetric between the eyes, and asymmetric cup-disc ratios should arouse suspicion of glaucoma. The larger the cup, the greater the probability of glaucomatous optic nerve. A cup measuring 1/2 the size of the disc or larger, a cup-disc ratio of 0.5 or more, raises suspicion of glaucoma. Disc hemorrhages are also a possible sign of glaucoma. A large cup should be suspected if central pallor of the disc is prominent. Because the cup is a depressed area of the disc, retinal vessels passing over the disc are seen to bend at the edge of the cup, a useful sign in evaluating cup size. Cup-disc ratio. In this non-diseased optic disc, the cup is less than 1/2 the diameter of the disc, indicating absent or low level of suspicion of glaucoma. Glaucomatous cupping. Patient's right eye shows a cup-disc ratio of 0.8, high level of glaucoma suspicion. The left eye shows a cup-disc ratio of 0.6, moderate level of glaucoma suspicion. The asymmetry of cup-disc ratio here also raises suspicion of glaucoma.
Few words about diabetes. The incidence of diabetes increased into modern world. That is why the family doctor will be familiar with diabetic retinopathy, which represents retinal vascular complications due to diabetes. Special attention will be paid on diabetic retinopathy cases when the patient has no complaint on vision. The explanation is, unless the changes involve the fovea directly, the patient develops severe retinopathy with no visual complaint.
Non-proliferative diabetic retinopathy. Dot and blot hemorrhages and exudates are shown scattered throughout the posterior pole. Microaneurysms, pinpoint dots, are difficult to see without high magnification. Exudates in non-proliferative diabetic retinopathy. Clusters of hard yellowish exudates are prominent in the superior aspect of the macula. The exudates extend to the fovea, threatening the central vision. Cotton wool spots in non-proliferative diabetic retinopathy. Microinfractions of the nerve fibre layer produce the lesions shown. Cotton wool spots are opaque and white, have feathery edges and obscure the underlying blood vessels. Venous beading and telangiectasia of the retinal vascula are shown. Proliferative diabetic retinopathy. Shown here is more advanced neovascularization of the optic nerve. These new vessels proliferate and extend into vitreous.
This underscores the importance of routine ophthalmoscopic examination in diabetes independent in any vision complaint absence.
Panretinal argon lasers photocoagulation. Shown here are old argon laser burns in the posterior pole of a diabetic patient with proliferative retinopathy. Initially, the burns are white, but with time they develop variable pigmentation from chorioretinal scarring.
Currently was evidenced that tight control not only of blood sugar but also at blood pressure, systolic less than 140 mm mercury, diastolic less than 80 mm mercury, slows progression of diabetic retinopathy.